Hello everyone, I am Dr Santosh Kumar, Orthopaedic and Joint Replacement Surgeon from Kolkata. So in our series we have been discussing about various orthopedic problems, and today we will be discussing one of the commonest orthopedic problems that we face in almost every family in our society, in our almost every street in our society, and that is knee osteoarthritis. Well, knee arthritis, especially knee osteoarthritis, is something endemic in the Indian subcontinent. What it means is that it is very common in the Indian subcontinent. Almost one or two members in our almost every families would be suffering from knee arthritis. 90 to 95% of them is osteoarthritis. Well, osteoarthritis is not a disease. It's a normal wear and tear of the knee joint, the way our car tires wear out. So this is the commonest arthritis, and this is osteoarthritis. Sometimes we have the lesser commoner arthritis of the knee. Most common of them is juvenile rheumatoid arthritis that we get. Juvenile rheumatoid arthritis or rheumatoid arthritis is something which is more than mechanical wear and tear. It's autoimmune wear and tear of the knee joint. Well, rheumatoid arthritis can be starting really very early in the age, like 12 years, 13 years, 14 years. It can start from 15 to 16 years of age also. In that case, it is known as juvenile rheumatoid arthritis or JRA. There is another set of knee arthritis which is known as rheumatoid arthritis, and normally it starts after 40 to 50 years of age, after 40 years of age. Well, rheumatoid arthritis affects not only the knee joint but various other joints in the body, especially the fingers, wrist, and along with that it may affect the knee joint also. In such cases, we have to treat the rheumatoid arthritis as a whole. We have to give medicines for rheumatoid arthritis, and of course we have to treat knee. If it is severely deformed, we have to go for knee replacement. Normally, the deformity, that is the bending of knees, is much more severe in rheumatoid arthritis as compared to osteoarthritis. Normally, rheumatoid arthritis tends to affect younger people than compared to the osteoarthritis age group. But still, the commonest one is osteoarthritis. It's not a disease as such. It's something which is wear and tear of our knee joint, the way our car tires wear out. And all of us are subjected to this osteoarthritis. Some people may have it earlier, some people may have it later, some people may have it more, or some people may have it less. But all of us will be subjected to certain amount of knee osteoarthritis. This knee osteoarthritis is mostly where we cannot locate a cause why it has worn out. In that case, it's called primary osteoarthritis. And sometimes this knee osteoarthritis is accelerated because of something else like a ligament injury or a fracture. In that case, it is known as secondary osteoarthritis. Well, in primary osteoarthritis, which is age-related, pure age-related wear and tear, in almost all cases, both the knees will be affected. But if it is a secondary osteoarthritis wherein there is one or more specific cause in which one knee has accelerated wear and tear, in that case only one knee may be affected. In rheumatoid arthritis also one knee may be affected. So the process of arthritis is a long drawn process, and it's an ongoing process. What it means is that it doesn't occur over a period of few days or few months. Arthritis, whether it is rheumatoid arthritis or osteoarthritis of knee, which destroys the knee joint, is a long drawn process of several years. And to start with, it's classified as early osteoarthritis, moderate osteoarthritis, and advanced osteoarthritis. In early osteoarthritis, we solemnly focus on muscle strengthening program. That is, the stronger the muscles of the knee, the stronger the quadriceps and the hamstring muscles, the stronger is the knee joint. So we focus on muscle strengthening program. In moderate osteoarthritis, muscle strengthening program is always there. Muscle strengthening is a pivotal part of treatment in all forms of arthritis of knee joint, whether it is early osteoarthritis, moderate osteoarthritis, or it is advanced osteoarthritis. So one basic part of the treatment is muscle strengthening exercises. The stronger the muscles, the less is the stress on the knee joint, less is the pain, and less is the further wear and tear. Along with that, once arthritis starts developing, especially in rheumatoid arthritis, there is bending of knees. In osteoarthritis also, knee bends. What it means is that in normal leg, we find that hip, knee and ankle is in one line. Hip, knee and ankle is in one line. That is the plumb line, the weight bearing axis of the body. So that is something which leads to normal walking, normal gait. So in arthritis, whether it is rheumatoid or osteoarthritis, but it's more in rheumatoid arthritis, the knee starts bending in one direction or in other direction, and majority of the cases is a biplanar bending. That means the bending occurs in two planes. It bends like this, it bends like this, and it may bend like this. So it is a biplanar bending. Now the issue of this biplanar bending is instability. There is instability. There is difficulty in walking. There is disbalance. That instability leads to waddling gait. There is waddling gait like this. Person walks like this, and there is increased risk of fall. Once the knee starts bending significantly, then there is difficulty in walking because of disbalance, which is imbalance. There is instability, and there is increased risk of fall. Almost all the people whom we see with fractured neck femur or other fractures who would have fallen in the house itself, in home itself, majority of them have bent knees. It's the bent knee which is the crucial pivotal role, which is the crucial factor in the fall. So bent knees leads to a risk of fall and instability in walking. So basically any form of arthritis of knee causes twofold problems. One is pain, and second is instability. This instability is because of bending of the knees. So how does the pain occur? The pain occurs because this is the knee joint is something like this. This is the femur bone and this is the tibia bone, and in between this we have something called cartilage, the cushion. Along with the cartilage there are multiple ligaments, there are washer shaped cartilages which are meniscus. So the whole thing wears out. The whole thing wears out like this. So this wearing out of the cartilage leads to bones touching with each other, and it leads to severe pain. And the wearing out of the wear and tear of the ligaments, the meniscus, the cartilages, the washer shaped cartilages, all of them, they lead to instability along with the bending of knees. So the pain to start with is only while walking or climbing stairs, and then the pain starts persisting. And it's several times, the pain persists even at the time of sleeping, and it may even increase at the time of sleeping. There may be a throbbing pain at the time of sleeping. So that is called neuropathic pain. So pain to start with is nociceptive, and then it goes to neuropathic pain. So pain is a basic issue in knee arthritis along with instability. Now in early form, moderate form, we always try to treat with muscle strengthening exercises. We use some dietary supplements like collagen peptide. In some cases, in very selective cases, the patient may benefit from something called viscosupplementation, which is injection of hyaluronic acid inside the knee joint. But capability of hyaluronic acid injection to do benefit or do good is extremely limited, and it is limited to the extent that I personally do not routinely advocate it. Routinely I do not use it. Sometimes in very severe pain, especially in rheumatoid arthritis, for getting temporary relief for few weeks or a month, we may inject a single dose of steroid inside the knee joint. But that should not be done routinely, and that is highly deleterious and disastrous if it is done routinely. It may be done once. So once the pain starts persisting and the person starts feeling that because of knee pain, the activities of daily living are hampered, the social life is hampered or the professional life is hampered, then one has to go for knee replacement. So whether to replace or not to replace the knees, it's a guideline which is based on the X-ray findings, wherein we see in X-ray that the knee is bent, the knee cartilage is worn out and bones are touching with each other. So one is X-ray finding, what we see in X-ray. Second is the clinical finding, how much the knee is bent, how is the gait, how unstable is the gait. And most importantly, how much is the functional impairment. Functional impairment means how much is the activities of daily living impaired and how much is the person's social and professional life impaired because of knee arthritis. So we have certain scoring criteria also, like the most commonly used ones is Oxford knee score. So if you want to know whether you need a knee replacement or not, or what is the best treatment for your knee problems, you can straight away go to Oxford knee scores. It's a live scoring system available on the internet on Google, and it can be scored then and there. Based on the scoring findings, we can decide the treatment that is needed. So this is just one of the examples of functional scoring as we may need to assess for knee arthritis. So once the activities of daily living are impaired and the professional and the personal life, the social life is being impaired because of knee arthritis, we would suggest a knee replacement. A person would need a knee replacement surgery. The whole goal of knee replacement surgery is to restore painless and stable movement. So on one hand, it is to decrease the pain. It is to decrease the pain. And second, it is to restore the stability. How it will restore the stability? It will correct the bending of knees. Like in normal knee, the legs are straight like this, and osteoarthritis it bends like this. After surgery, it is again corrected like this. So the bent knees are corrected after knee replacement surgery. And what is basically knee replacement? It is replacement of the surface of the worn out cartilage. For example, this is the worn out cartilage, this is the worn out cartilage, and this cartilage will be replaced by a new surface. So this is knee replacement. In knee replacement, basically it is a surface replacement. It is resurfacing. It is a surface replacement wherein the worn out surface is replaced by a new surface which is known as implant, and the deformity, the bending, the knee which was bent like this is again corrected like this, and the knee folds fully. In the knee osteoarthritis, the knee is bent and several times the knee doesn't fold fully. In that case, knee replacement increases the folding of knees as well as it corrects the bending of the knees and it restores stability. It gives painless and stable movement. Now I will come to the various questions that people have in their mind. I keep on getting and everybody keeps on asking. So first question is, everybody asks that, is there a way out other than knee replacement? So my answer would be that knee replacement is, I personally and almost all surgeons never ever recommend knee replacement if there is a way out. What it means is that we recommend knee replacement only when we feel that knee replacement is the only solution. So once the knee has bent, once the cartilage has worn out, once there is persistent pain and instability, knee replacement is the only solution. Of course, muscle strengthening exercises is always helpful, but in that case, once the deformity has developed, viscosupplementation, that is injection, other electrotherapy or other modalities of traditional treatment do not help, in my opinion. So if a person is having severe osteoarthritis or severe arthritis of knee which is incapacitating his or her functional abilities or activities of daily living, then probably knee replacement is the only solution. Now the other question that immediately one asks is that will it be successful? Well, success depends, the amount of success depends on the team which is doing it. If for example we are doing, I and my team, we are doing knee replacements, knee arthroplasty surgeries daily, many knee arthroplasty surgeries daily, then our results are very predictable. And also on the other hand, knee replacement or any joint replacement surgery, it's all about mechanics, it's all about precision, it's all about physics. So once the mechanics is perfect, the precision is perfect, the technique is perfect, then it is highly likely to be successful. And hence I would say that knee replacement or any other joint replacement surgeries are very predictable. It is very predictable. So once the surgery takes place, the pain disappears and the person has painless and stable movement. I would say that it's a life-changing surgery. Majority of them are life-changing surgeries. Another very common question that people ask, how long will it last? So majority of the well-done knee replacement surgeries would last for more than 20 to 25 years average or even more. Now many would puzzle, what is the correct time to do knee replacement? For example, a person may be troubled because of knee arthritis at a younger age also. Especially there are certain kinds of, initially itself I mentioned, there are certain kinds of arthritis like juvenile rheumatoid arthritis which can start at an age of 20 years, 25 years, and the person may need a knee replacement at the age of 27 years, 28 years. The youngest person whom I have personally done knee replacement very recently was at 27 years of age. So in juvenile rheumatoid arthritis, person may need knee replacement at 27 to 30 years of age also. In that case, we clearly counsel the person that in next 25 to 30 years, you will need another knee replacement, and that is known as revision knee replacement. So revision knee replacement is as successful, as predictable as the first knee replacement. So if somebody is thinking what is the correct age of doing knee replacement, that is the commonest question. So my answer would be that if you need knee replacement, whatever may be the age, you have to go for it. What it means is that the criteria for doing knee replacement is impairment of activities of daily living, impairment of social and professional life. It is the functional incapability, it is the functional incapacitance. It is not the age. that requirement is at the 30 years of age, it has to be done. If that requirement is at 60 years of age, it has to be done. If the requirement is at the 75 years of the age, it has to be done. Well, at every age, there is different functional aspect which one needs. In younger person, they need to do knee replacement in a severely affected knee to preserve the activities of daily living, to preserve the social functions of the person, to preserve the professional functions of that person, professional work of that person. And in senior citizens, we may need knee replacement to preserve the stability. Otherwise, bent knees, they will fall down and have fractured neck femur. So at every age, there is different aspect of doing this. There is different vision, there is different need for doing this knee replacement surgery. Before any surgery, we do all routine pre-operative investigations to assess one's fitness for surgery, and if needed, we may need to optimize a person before admission. Many people keep on asking that why don't we admit the patient and then do the investigations? Well, this is something which is not preferred. We always do the routine tests before surgery, before admission, and once fitness for surgery is established, then only we go ahead with surgery. If there is any need of optimization, we always optimize the person and then only we do surgery. Many of us are bothered about the safety. For my side, I would like to confirm everybody that it's our teamwork. As a surgeon, we always team up with our physicians, with our anesthetists, with our physiotherapists, with our cardiologists, with our nephrologists to work as a team, and we ensure that everything is done safely. Safety is first. We never compromise on safety. So safety is something which is first, and then only we do anything else. Several times we may need to do both knees together in same sitting. Several times we do one knee at a time. So a lot of people ask this question, whether it is good to do both knees together in same sitting, whether it is good to do both knees together, or we should do one by one. Well, it can be done in three ways. First, that we do most commonly is both knees together in same sitting. That is known as bilateral simultaneous total knee replacement. Some cases we do one knee, give a gap of 4-5 days or a week, and then we do the second knee in the same admission. That is known as bilateral staged knee replacement. Third is we do one knee surgery and we discharge the person goes back home, recovers fully, and then he or she thinks of the other surgery. So that is known as unilateral knee replacement. Well, I prefer normally both knees in single sitting, or we do one knee and we discharge the person. We ask him or her to go home, and then once the person has recovered from one knee, then he or she gets admitted for the second knee. Normally, I and my team, we personally do not prefer to do surgeries in a gap of 4-5 days, because if we do both surgeries in single sitting, then even if both knees are being operated, but medically and physiologically it is one surgery. But if we give a gap of 4-5 days, it becomes two surgeries. Twice you have to give anesthesia, twice you have to give IV saline, IV fluids, analgesics, and that leads to further weakness. But all these things have to be decided in discussion with the team in which person is operated. This is my personal opinion, and it can very much vary from other surgeons, but this is my personal opinion. It's better to do in one sitting rather than to give a gap of 4-5 days. Now, in several cases, the people come to us for surgery in a very late stage. The knees, which should be straight like this, are bent like this. So if we do one knee and then send them home, then one knee gets corrected like this and other knee is still bent. So people feel up and down and they feel instability. So we may do both knees in two sittings very well and very good. That's good option. But the process is eventually complete only if the second knee is also done. Means the walking will normalize only if the second knee is also done. So that may be done in two sittings or may be done in one sitting. Of course, the final decision is taken after seeing all the medical reports. We have certain criteria. Most important for any knee replacement or any other orthopedic surgery is to see the heart and the kidney function. So if heart function is good, kidney function is good, if hemoglobin is good enough, then we may proceed with both knees in single sitting. If there is any issue, we may prefer to do in one knee at a time. So the final decision, of course, it is taken after seeing all the reports, and then only we proceed. People often keep on asking, which is the best implant, which is the best implant, which is the best implant. We will always prefer the best implant, and I also will always prefer the best implant. But the question is there something called best implant? Probably it's not like that. Most of the implants that that are available are all international quality implants. They are all implants with long follow-up. Most of them are either made in USA or Germany or even in this country. So most of the implants have long follow-up, and most of them are very good. Almost all of them are very good. The success, the results, the longevity, the performance of the knee replacement surgery or any other joint replacement surgery depends on the precision, the technique which is being used. Of course, there are newer things which may seem very lucrative, like robotic surgery, there is navigation surgery, there is custom implantation, there are custom made jigs which are known as patient specific instruments, and all those things are there. These things are really good. Computer assisted surgery and navigation surgery is really good. But still, the most important factor which sits over and above everything is the surgical experience, the surgical technique, and the surgeon's experience, the surgeon's capabilities. In my opinion, they are still the supreme, and that is what decides everything. Everything else comes below that only. Whatever you think of computer navigated, robotic, whatever you think of patient specific instrumentation, everything is below the surgical experience and the expertise. So most important thing would be the surgical experience and the expertise. Many people ask me whether a person with diabetes can have knee replacement, a person after bypass surgery can have knee replacement, a person after angioplasty can have knee replacement. What I would like to say that most of the people whom we are doing joint replacement, knee replacement, most of them are senior citizens. So they are affected with some or other medical comorbidities which are always there, and we take care of everything. As far as diabetes is concerned, diabetes per se has never been a factor creates any problem in knee replacement surgery. I have never seen diabetes per se has never created any problem in knee replacement surgery, provided that diabetes has not affected the kidneys. What it means is that the blood sugar levels do not directly interfere with our knee replacement surgery. But what we have to see is whether there is end organ damage because of diabetes. What it means is that we have to see whether the kidney functions are preserved in diabetes. There should be no diabetic nephropathy, and if at all it is there, it should be managed. Maybe in that case we may need to do 1 year at a time. We have to see that the heart function is not compromised because of diabetes. So we have to see all those things. Blood sugar as such generally doesn't create any problem in knee replacement surgery. After admission, we keep on checking the blood sugar levels thrice a day. We use multiple modalities of blood sugar control, which includes medicines. There are long acting insulins, single shot long acting insulins. There are rapid acting insulins which may be given thrice daily at 8 hourly interval. So we have multi-modalities approach for blood sugar control. Now, as far as other things are concerned, like some people may have bypass surgery and they have to undergo knee replacement surgery. Some people may have angioplasty done and then they have to go for knee replacement surgery. We have to analyze everything. We have to see the cardiac function. A heart in which bypass surgery has been done may be more effective, more younger than a heart in which there has been a problem but still bypass surgery has not been done. So bypass surgery being done is not something which is a deterrent for knee replacement surgery, and in several cases it may be good. The heart may become more efficient after bypass surgery. As far as angioplasty is concerned, we need to see whether the person is taking any blood thinner medicines like clopidogrel, and if a person is taking those blood thinner medicines, it has to be stopped 7 days before surgery. Now, if it is a recent angioplasty, let's say like 6 months, 8 months, then we may not be able to stop those blood thinning medicines. If a person has undergone angioplasty in last 6 months, then we may not be able to stop those blood thinner medicines, and we may have to wait for 6 months after an angioplasty to do a knee replacement surgery. Well, of course, if there is any issue with heart or kidneys and all, the heart and kidneys have to addressed first. Knee replacement comes only after that. So knee replacement is not an emergency. We can always plan that. If somebody is having a pacemaker and then undergoing a knee replacement surgery, we make sure to check the ECG. We make sure to check the battery of the pacemaker, and if needed, we change the mode, and we ask the technician, the concerned technical team of that pacemaker, whether it be commonest brands of pacemakers that are being used nowadays, Medtronic, St. Jude. So we get in touch with them, and they do the basic checkup of the pacemaker, and then we proceed for surgery. So by and large, knee replacement surgery is very, very safe, and we take care of all the medical issues before surgery. Something which bothers most of our people is will we have pain after knee replacement surgery? Well, that is something which bothers us also equally. We are also extremely sensitive to your pain. We never allow you to get pain. So for that we have the recent modalities, like we have something called ultrasound guided nerve blocks. What it means is that the nerve which carries sensation from the knee joint, so that nerve is blocked using by local anesthetic and steroid. That nerve is blocked before surgery itself using ultrasound guided, high frequency ultrasound guided images. So once that nerve is blocked after surgery, the person will not experience any pain. The concept runs like this. The concept is that we close the gate of the pain before the pain would come. So after that the pain doesn't come much. The nerve block, which is selective sensory blockade, means the person will be able to move the legs but there will be no pain, and that nerve block stays for 24 hours, mostly 24 to 36 hours, but the concept is that it closes the gate of the pain and the pain doesn't come much after that. So this is how nerve block works. After surgery also we have multimodal pain control modalities, like we have transdermal patches, we have certain medicines, we have certain medicine for nerves which to control neuropathic pain, and by and large the experience after knee replacement by and large is painless. So what we call it is as minimal pain. It is almost always minimal pain, and sometimes it is absolutely painless. Along with that, we use several other modalities also to control the pain. Very obvious question will be, how is the recovery after knee replacement? How fast one recovers after knee replacement? Well, knee replacement, as I initially explained, this is the implant which is being put. This is a surface replacement, and this is put with something called bone cement. So that's a polymerization reaction, and that it gains its maximum strength right on the operation theatre itself. What it means is that the cement sets within 10 minutes and the implant becomes fully strong within 10 minutes. So howsoever strong it has to become, it becomes within 10 minutes. Mobilize the person full weight bearing from the very next day of surgery. What it means is that we ask the person to get out of bed, hold a walker for balance, and then put full weight on the knee and walk from the very next day. Along with that, we start physiotherapy, which is mainly muscle strengthening exercises. To increase muscle strengthening exercises, we give lot of cool pack and ice compress for the inflammation to subside, and a person starts walking from the very next day of surgery. We keep the person normally for 3 or 4 days after surgery. By that time, one is able to go to washroom independently, holding a walker of course, climb a few steps stairs, and normally after that we discharge the patient. After discharge, it takes around 10, we review the patient again after 10 days or so, and then the stitches are removed. Of course, presently we have something called stitchless surgery, in which there are no stitches are put and no need of any stitch removal. We specifically use it for people who are out of station, who have difficulty in coming so fast. So we use stitchless surgery, and then stitchless surgeries, there are no need of stitch removal. One can shower, but we have to protect the dressing for the 1 week or so. And after the stitches are off, after 10 days, one can shower normally, and the whole area is washed with soap and water. Initial few days, normally we take the help of a physiotherapist for around 2 to 3 weeks for the patients to teach muscle strengthening and knee bending exercises. So the whole focus is on the strengthening of the knee muscles, the strengthening of the hip muscles, and strengthening of the back muscles and knee bending. Along with that, as much as possible, every 2 to 3 hours, we have to give cool pack or ice compress. So that takes care of the inflammation. And normally by around 6 to 8 weeks, a person starts walking outside the home independently, and full recovery in 2 to 3 months, a person can go out station for on a hill station, and after 3 months or so, person can go even for trekking. So what activities are allowed after full recovery of knee replacement? Activities that are allowed are unrestricted walking, stair climbing, cycling, swimming, driving, trekking, everything can be done. Only thing, of course, presently we have high flexion knee, which allows a person to sit cross-legged on bed. Sitting cross-legged on bed can be routinely done. It's not an issue. Sitting cross-legged on bed will take around 3 to 4 months to come, because the whole knee bending, subsidence of the swelling takes place around 3 months, and the complete knee bending takes place around 3 to 4 months. So sitting cross-legged on bed will come around 3 to 4 months. Person Presently we use something called LCS, that is rotating platform high flexion knees. LCS, also the full form is low contact stress knees. So with these knees, what we are using presently, a person may sit on ground also on a very special occasions, but it must not be done routinely, because sitting on ground may decrease the life of the implant. But of course a person can sit cross-legged on bed. High impact activities have to be avoided, like running, jogging, jumping, skipping. All those high impact activities have to be avoided after knee replacement. Other than that, almost everything that a normal person can do can be done after knee replacement. So these are the issues that most of us keep on asking about knee replacement. And along with that, I would like to add another thing. Presently we are using full titanium implants which are absolutely MR compatible. You can do full body MRI after those implants, MR compatible knees, which are available here. And this is the most advanced type of implant that we are using, full titanium knees. This is fully MR compatible knees, whole body MRI can be done, and those knees would not be detected in metal detectors also. So these are the common queries that we get regarding knee replacement surgery, and I have tried to address them. If you have further queries, you are most welcome to send it on our WhatsApp number 9831 911 584 or email us at santdr@gmail.com. We will be very happy to address all the queries, and we will discuss it further in the subsequent issues. If you are somebody who wants to travel from outside Kolkata to Kolkata for this surgery, we will assist you in all possible ways. If you are a foreign citizen, we will assist you in getting medical visa. If you are somebody who is coming from out of station, we will assist you in your stay, your travel and everything, and we will make sure that right here in Kolkata you get the world's most advanced at the world's most affordable rates, all kinds of orthopedic surgery. So all of you are welcome to Kolkata for any orthopedic surgery. Thank you.